Dear friends, thanks so much for joining me. My name is Murray Grossman from the Penn Frontotemporal Degeneration Center. I'm here to present some brief summary videos of our annual Caregiver Conference. This year, we've decided to postpone our conference because of the COVID-19 emergency. We're concerned about practicing social and physical distancing. Therefore, we're postponing our conference until November 13th, 2020. In the meantime, I'd like to present you some brief summaries of our presentations. Before I continue, though, I should say a couple of words about the special impact of COVID-19 on FTD. First, it's important to say that there is no increased susceptibility to COVID infection because of FTD. There is a theoretical association because of progranulin mutation carriers having partial immunocompromised status. We should nevertheless continue to practice physical and social distancing. We have to be careful because of the consequences that this has on our loved ones. We have to be able to manage individuals who have reduced insight and can't understand the consequences of physical and social distancing. We have to be concerned about disinhibition and physical and social distancing, and also we have to be concerned about apathy and the problems associated with reduced sanitation. Progressive aphasia has communication difficulties, and so there are also some exacerbations associated with physical and social distancing. So all of these things should be kept in mind. We have important hints from our social workers about structured curriculum activities that incorporate social distancing and cleanliness. And hopefully these will help over the course of the next few weeks. And I want to emphasize how important it is for you to take care of yourself. For you and your loved ones, it is so important for you to be at your optimum level of functioning. My talk today will involve a brief review of the clinical characteristics of frontotemporal degeneration, or FTD. I'll talk a little bit about primary progressive aphasia and behavioral variant of FTD. Both of these have associated motor disorders that I will mention. I focus on these clinical characteristics because they have pathologies that are associated with FTD. One pathology is tau, and the second is TDP-43. And each of these has an association with clinical characteristics. This association is statistical, so it's just a probability, and we want to increase our assuredness about the likely underlying cause of FTD, so we have biomarkers that help determine pathology during life. These include imaging, cerebrospinal fluid, and genetic assessments that give us the likely cause of a form of FTD with higher assuredness. This is important because there are treatments associated with FTD, and we want to make sure that individuals are participating in treatment trials that are likely to be of benefit. And finally, we'll talk a little bit about day-to-day management. So, as many of you know, primary progressive aphasia and behavioral variant of FTD each contribute to about 50% of FTD as it occurs. And this is what we find in our clinic as well. I will first talk about the different forms of primary progressive aphasia that we see. The non-fluent and agrammatic variant of primary progressive aphasia is marked by slow and effortful speech. This is associated with an impairment of grammatical expression, where people string words into a sentence but leave out the small little words that help join words together into a sentence. We know that this is not simply a measure of motor problems because there are also difficulties with grammatical comprehension. And nevertheless, we do see some speech errors. Taken together, these problems are associated with a reduced frequency of the words we speak in a minute. And as you can see in this yellow bar, individuals with the non-fluent agrammatic variant of PPA speak at a rate of about 50 words per minute, which is about 1/3 the rate at which normal speakers speak, which you can see here. This characteristic speech is associated with an elevation of phosphorylated tau in the cerebrospinal fluid. We find a correlation between the level of phosphorylated tau that you can see here on the x-axis and the kind of speech characteristics that we see as people are speaking on the y-characteristic. And you can see the association here. Progressive supranuclear palsy and cortical basal syndrome are involuntary motor disorders. These are associated with tremors, an abnormality in eye movement, and unexpected falls when walking. Folks with progressive supranuclear palsy and cortical basal syndrome also have similar kinds of language disorders, and in fact these language disorders can precede the motor impairments. When we look at pictures of the MRI scan, the blue areas show areas of atrophy that we see in individuals with non-fluent agrammatic PPA, and the red areas in this study right here are associated with grammatical and speech deficits in the left frontal lobe. This is an illustration of a brain of an individual who had non-fluent agrammatic PPA. And you can see the area of atrophy that is in the left frontal lobe here. About 75 to 80% of individuals with an APPA have a tauopathy. And when we look microscopically at the brain, we can see evidence of this pathology in some of the brain cells. It's important to point out that about 90% of individuals with progressive supranuclear palsy or cortical basal degeneration also have a tauopathy. We have symptomatic treatments that we can offer to individuals with naPPA. We have a form of speech therapy that can enhance speaking, and we help with transcranial direct current stimulation delivered at the same time that seems to enhance performance. There are also disease-modifying treatment strategies for individuals with tau pathology, including blocking the accumulation of tau and blocking the spread of tau throughout the brain. We have treatment trials that are attempting to pursue these treatment strategies, including an antibody-mediated tau clearance of tau from patients with PSP, and there is a planned trial for individuals who have a naPPA mutation that is associated with the accumulation of tau pathology. Our research program targets the improvement of biomarker measures that are needed to monitor responses during these treatments. A second form of progressive aphasia is called the semantic variant of PPA. These individuals have difficulty with fluent and speech that is nevertheless associated with impaired naming or difficulty with word finding. There are comparable difficulties with comprehension, where there's difficulty understanding the meanings of words, and this can be associated with difficulties understanding the meanings of objects. Hence, we refer to this as a semantic impairment that underlies this form of PPA. This is associated with atrophy in the temporal regions of the left hemisphere, particularly the parts of the left temporal lobe that are the furthest forward or anterior in the brain. I should mention that there is another form of neurodegenerative disease that is allied to semantic variant of PPA. This is Lou Gehrig's disease, or amyotrophic lateral sclerosis. The core component of ALS is a motor disorder, but we find that 50% of patients with ALS have some cognitive deficits or have some behavioral deficits associated with the motor impairment. This is the picture of a brain of an individual with the semantic variant of primary progressive aphasia. You can see in the area of the temporal lobe that there is significant atrophy or shrinkage of the brain. This is a picture of the brain turned sideways, and you can see the atrophy more clearly in this part of the temporal lobe. And when we look microscopically at the brain, we see evidence for TDP-43 pathology. This is present in about 85% of individuals with semantic variant PPA and present in more than 95% of patients with Lou Gehrig's disease or ALS, which is why I mentioned these together. We have symptomatic treatments that we can offer for individuals with semantic variant PPA. We have speech therapies that are also enhanced with delivery of transcranial direct current stimulation. And there are also disease-modifying treatment strategies for individuals with TDP-43 proteinopathy. Our current focus is on inherited forms of TDP-43. One form of therapy is associated with an antibody that helps increase the progranulin levels that are low in individuals who have a mutation of progranulin that is associated with TDP-43 pathology. And a second form of therapy is a vector-mediated gene replacement therapy that is pending. And again, our research program is associated with the biomarker measures that we need to monitor the response during treatment trials. Behavioral variant FTD accounts for the other 50% of individuals who have a form of FTD. There are several changes in behavior and personality that we see in individuals with behavioral variant FTD. One form we refer to as disinhibition. This involves poor self-regulation, impulsive behavior, and impaired social conduct. Individuals will engage in unusual behaviors, walking up to strangers on the street, making inappropriate comments, for example. Another characteristic of behavioral variant FTD is rigid or obsessive or ritualistic behaviors. These are repetitive behaviors that can be simple in nature, as simple as tapping or humming, or can be quite complex, involving a variety of collecting behaviors, for example, or engaging in unusual kinds of beliefs. This can occur not uncommonly in individuals with SVPPA. Finally, many individuals can present with increasing apathy. This is a disorder of goal-directed behavior where there is difficulty initiating behaviors and difficulty with motivating behaviors. This can occur more prominently as any form of FTD progresses over time. Folks with the behavioral variant of FTD can have limited insight into their unusual behaviors, and there is poor empathy or poor recognition of the disruption that these kinds of behaviors are causing. And this has great impact on caregivers who have poor recognition for all of their care for their loved ones who have behavioral variant FTD. Finally, folks with behavioral variant FTD have executive deficits. These are difficulties with planning and organizing that can impair judgment and result in problems such as being scammed. The underlying anatomy of the behavioral variant FTD affects both the left hemisphere and the right hemisphere and the frontal and temporal regions of the brain, as you can see in these color images. And this also illustrates that there tends to be more pronounced disease in the right hemisphere. There are several symptomatic treatment options for managing some of the behavioral disorders associated with BVFTD. Among these are medications such as atypical neuroleptics and anticonvulsants and antidepressants that we borrow from other neurological conditions. Also, behavioral management is very important. This includes a structural environment, curriculum of activities that can help individuals be engaged during the course of the day, and minimizing exposure to provocative agents. We're also developing an app to help with initiating and motivating activities. Behavioral variant FTD is associated half the time with tau pathology and half the time with TDP-43 pathology. So it's difficult to determine simply on the basis of the behavioral features which form of pathology is underlying an individual's behavioral variant FTD syndrome. So this is where biomarkers are particularly crucial for helping to define pathology during life. And a biomarker does this used in a minimally invasive fashion. As I've mentioned, these are useful for diagnosis, for disease-modifying treatments, and useful for monitoring the response to see whether a treatment is effective during a treatment trial. There are three kinds of biomarkers that we work on at the Penn FTD Center and are pursued by colleagues around the world. These include genetic markers, imaging markers, and biofluid markers. By biofluid markers, I'm referring to cerebrospinal fluid that we obtain following a lumbar puncture, and also more recently, blood markers. As far as genetic markers are concerned, we know that about 25% of individuals with FTD have a strong family history. And this can provide definitive information about the cause of FTD. In about 80% of individuals with a strong family history, we can define an inherited form of disease. The most common forms of genetic FTD are a mutation in MAP-tau that is associated with tau pathology. A second is mutation in the granulin gene that causes TDP-43 pathology. And the third is C9orf72 that is also associated with TDP-43 pathology. While these cause the vast majority of genetic forms of FTD, there are also many less frequent forms of genetic disease that can be associated with FTD. Most individuals do not have an inherited form of FTD, so we need other markers for individuals who have sporadic disease or non-inherited disease. One form of a biomarker is imaging. I've shown you some images earlier that look at MRI and the distribution of atrophy on MRI scans. We also have molecular PET imaging that can help us with specific forms of brain pathology. These are some images showing elevation of uptake for a tau PET marker in progressive supranuclear palsy. And you can see these areas of red here show increased forms of pathology. And in mild diseases, you can see some uptake, and you can see that the uptake increases in more severe diseases. We know that this is associated with underlying tau pathology because in individuals who've passed away, and we have PET scan, and before they passed away, we can see these ante-mortem biomarkers. We also look at cerebrospinal fluid biomarkers. I've mentioned phosphorylated tau, and more recently we've been performing studies looking at neurofilament light chain, or NFL. In this study, we're looking at the association between levels of NFL and naming. Elevated levels of NFL, you can see here on the y-axis, are associated with increased disease. On the x-axis, this is performance on a naming measure, and you can see that as performance on the naming measure is reduced, there are higher levels of neurofilament light chain. When we look at the imaging studies in these individuals, we find that the elevated level of NFL and naming difficulty overlap with atrophy that we find on the MRI scans in this left temporal lobe, an area of the brain that's associated with language difficulty. And when we look longitudinally, we find that as cognitive performance declines, in this case looking at MMSE, this is associated with neurofilament light chain levels. So this is also, neurofilament light chain is also a good prognostic marker. The NIH goal is for effective treatment by 2025. Working together as a team, we can achieve this goal, and we're so proud to be able to work with you. And we hope to see you in person on November 13th, where we can discuss these and other issues face to face.